welcome back to the Good Summit here in Trinity College, Dublin. It's my pleasure to be hosting this panel this afternoon on good health and well-being. My name is Ivana Bacik and I'm a Labour TD or Member of Parliament here in Dublin Bay South in this constituency, and also a sometime lecturer in law here in Trinity. And we have a wonderful panel this afternoon, a great combination of different levels of expertise and experience and knowledge. And we have the very broad remit of discussing good health and well-being. What does it mean to have good health and well-being as normal sociological states of play? And how can we know if medical advances in science are truly making their way and making progress in marginalised communities? So I'll just introduce our panel, and then we will commence the discussion. And I know it will be as free-flowing and engaging and stimulating as the earlier panels were this morning. So first of all, we have Gareth Presch, who's the founder and CEO of the World Health Innovation Summit. And Gareth, apologies, my surname has always been mispronounced, so apologies, I should have checked if I had pronounced yours correctly. Gareth is a social entrepreneur, founder and CEO of the WHIS, and he is also an expert lead on the Sustainable Development Goals, particularly 3 and 4 for the UNGSII Foundation, and has advised and been a member of a number of different successful fundraising events for charity. So he has a very long and very illustrious CV in the social entrepreneurial sector. Secondly, we have Professor Cliona Nichali, who's a Trinity colleague and Associate Professor Consultant in Clinical Medicine here in Trinity, also Clinical Lead at Inclusion Health Service at St James's Hospital, which is one of our big teaching hospitals, of course, and her work is aimed at improving access to hospital care for homeless and other marginalised communities, and she has medical expertise in a range of areas, including addiction and memory and other cognitive processes, and she uses sociological influences on health. So that's a great fit with the discussion we have. Thirdly, then, from the other university in Dublin, we have our great friend and colleague, Professor Orla Hegarty, who's Assistant Professor in UCD, in the School of Architecture, Planning and Environmental Policy, and Course Director for the Professional Diploma in Architecture. And Orla is very well known to audiences here in Ireland as a contributor to national broadcast and print media on topics of built environment, construction industry, and the hottest political topic of the day here, housing and accommodation. And she's appeared as an expert witness within the Oireachtas, our parliament, and has also done a great deal of work on the built environment and related issues. And finally, I think we're going to be joined online, yes, as if by magic, he appears, James Sanderson. And James, you're very welcome here to Dublin and to Trinity College. James is Director of Personalised Care at NHS England, or National Health Service, of course, and NHS Improvement. And he leads on implementation of universal personalised care, and is also responsible for National Palliative and End-of-Care Life Care Programme. And he became CEO of the National Academy for Social Prescribing in 2019. And that's one of the topics we want to examine in this afternoon's panel. So James, you're very welcome to join us today. What I'm going to do is ask Gareth to start us off in our discussion. As I say, it's a broad remit to look at global health and well-being and good health and well-being, and we can obviously keep it as focused or as broad as we like. But perhaps you'd like, Gareth, to set the scene for us as founder of the World Health Innovation Summit. What does that mean? What are the challenges and opportunities for good health and well-being around the globe? And there's one obvious glaring answer I know was discussed at length in the previous panel. But what are the challenges and opportunities more generally as we emerge very slowly and cautiously through this pandemic?
So, I mean, it's a very broad topic, but I'll try and get straight to the point. And I think COVID has exposed our health system as it currently stands. But it's also shown how well we've come together to solve problems, particularly from a medical and scientific perspective. But it gives us a huge opportunity to build the future of healthcare. And what does that mean? And I suppose we have to set the scene and what are the challenges that we face at the moment. And the real challenges for the health system is around recruitment and retention. And we have a real problem around, in the future, we're going to be short of about 18 million staff. But I don't want to focus on those particular challenges. I want to look at how in the future do we promote good health and well-being, which is a sustainable development goal, which you mentioned. How do we actually use what we currently have and promote good health and well-being and create new and meaningful jobs at the same time, while delivering an improved quality of life. And that's a very big topic, and it's a hard one to nail down. But my colleagues here are going to kind of, shall we say, explain how we do that. But the World Health Innovation Summit, that's a platform that's been set up to co-create those solutions, to bring the expertise together, to bring knowledge and transfer that knowledge using the modern technology that we have. And we can share knowledge, quite rapidly now. We'll have colleagues that are joining us from around the world here. James is joining us online. So we have that opportunity. I think from the global context point of view, Sustainable Development Goal number 3 focuses on good health and well-being. We need to move the knowledge base that we have around disease to a salutogenic approach, which is promoting good health and well-being. So there where the opportunities lie, because in the future, we have an aging population, we have, massive challenges ahead. How do we come out of COVID? Where do we put the investment? Okay, where does the investment lie? How do we generate value out of healthcare? Because as we've seen with the economy, COVID has cost the economy $11 trillion. Now, if we had to put the preventative measures in that were recommended during Event 201, for example, we would have saved a lot of the hassle that we have now at the moment. So it's about planning for the future. So I hope that myself and my colleagues can explain to you how we can do that.
Gareth, thanks so much. And I think that's the real attraction of an event like this, a good summit, is where we look at different cross-disciplinary and interdisciplinary ways of engaging with pressing issues, like how you address Sustainable Development Goal 3 on promotion of global health. So Cliona, coming to you and your work in St. James's Hospital and with marginalised communities in accessing healthcare, where are the lessons from Ireland that we can perhaps adapt and deploy for other communities around the world?
I think because of our history in Ireland, there is a real commitment to equity and to looking out for those who have less on a personal level. I think our structures don't always enact that, but on an individual level, people are pretty motivated by making sure that everybody is included and well. And I think that Irish people are really good in a crisis. We're not always great at the planning part. My husband is Finnish, so I always contrast to what they do there. If there's a crisis in Finland, it's the end of the world because nobody's used to having them, whereas here we have a crisis several times a day. So we're quite flexible. So I think those are the strengths. An example that comes to mind for me at the moment is around COVID and homeless people. So, both you and Orla will talk more in detail about the terrible housing crisis that we have in Ireland, which I think is a real indictment of our political system and our society, which I see every day in my work, the extremely severe effects that it has on people's health and the huge costs that it incurs. So it's false economy to not address it in so many ways. But as a result of seeing those health inequalities, we had a network really set up by Austin O'Carroll. For those of you who know him, he's absolutely amazing and a real thinker. A network of health and social people working in health and social care who were very interested and invested in improving health for people at the edges of society. So when COVID struck, I think we were in a good position in that we were aware of the risk that we were going to see a huge outbreak of COVID in homeless people, particularly in the dormitory-style accommodation that's not good for people's health at the best of times, let alone during a pandemic. And we were able to put that crisis management, and I think the Irish way of doing a lot of things on relationships and friendships, and very quickly we were able to decongregate, so move people into hotel settings with addiction support by a Buddhist addiction charity and methadone being delivered, and we managed to prevent major outbreaks of COVID in homeless people in Dublin. And we also saw unsurprisingly huge gains in their health anyway, because health is you can't separate it from people's social well-being and their physical environment. So I think that was a real lesson on what we can do well, and I'm really proud of it. And I think the challenge now will be the planning piece and those big structural pieces that need to be done to mean that we can move from a crisis to a better place. And I think it's coming back to what Orla will be able to talk much more on, but we need more physical properties. We need more homes, physical homes for people. We understand the importance of social determinants of health, but how do we build that into our systems to make sure that they're there? For many reasons. Yeah, that's it.
No pressure then. Not a big...
No pressure. And Ivana, this is all up to you now because you're in the Dáil.
I should say I was just elected to the Dáil this summer, having been in the Senate or Seanad for some years before. So yeah, it is. It's certainly a challenging time politically to plan for the emergence from COVID, but there are useful lessons. And I suppose, Cliona, when you talk about your husband being from Finland, I can't resist but remind anyone watching of the wonderful victory last night that the Irish women's soccer team had over Finland. So our soccer team won 2-1 over Finland, and let's say the outsiders won there. So hopefully we'll make the World Cup for women's football. On a more serious note, you're talking about what we did well in terms of decongregating settings, in terms of preventing the worst of COVID among homeless populations, and the great work Austin O'Carroll has done, and you know, he really is an inspirational doctor. But Orla, if I might come to you to just pick up from that, you know, where did we do well, but where also could we have done a lot better in managing COVID? And again, the lessons for how we move beyond COVID to restructuring our communities for better health.
Thank you. I'm really glad Cliona started with housing and particularly homelessness, because I spoke to people in Galway Simon community last week, and similar experience. They did great work and often overcame institutional barriers and built on relationships and kept people safe. But more broadly, I think we've started to think about housing as property, and in fact everybody goes somewhere every night, you know, and I think some of the lessons of the pandemic have been how much poor quality housing is a driver of the pandemic. Just to give you to bore you with a few statistics, people who are not in overcrowded housing last year had half the rates of COVID of the people in overcrowded housing. People who were in unsuitable housing, like traveller accommodation, homelessness accommodation, direct provision, had very high rates of transmission. That is all preventable by how we make our buildings and how we make our housing. People in nursing homes. I mean, again, another shocking statistic. We have about 2.5 million buildings in Ireland. Half of the people who died here were in 400 buildings. They were infected in 400 out of 2.5 million, and in entirely preventable conditions. And when you look around and you see that we haven't prepared for this winter, I have to say I find it very frustrating. I've come here today with my air quality monitoring, and the air conditions in here are excellent, which is why my mask has been taken off. But I suppose I'd like to reframe the pandemic a bit, and it's a more broadly into health. We haven't tackled the pandemic in terms of prevention. We've treated it as a medical crisis. It's an environmental crisis. It's very connected to climate change, and it's been exacerbated by the fact that we have under-engineered and overcrowded our buildings. The driver of the pandemic is very particular conditions that can arise in buildings, and they're measurable, as you see, and they're preventable. And we don't have to be where we are. We're heading into a very difficult winter again. I think people have lost a sort of situational awareness of where we are this October. I also think people were blind to what was coming in October with an over-reliance on vaccines, and that's maybe because the pandemic has been medical-led rather than multidisciplinary-led. And I think the learning from the pandemic will be that this didn't happen to happen at all, and that we will have lots of new viruses and diseases in the coming years, but we don't have to have conditions that allow them to become a pandemic. So there's a difference between a new virus and it becoming a pandemic. And we just need to do enough now to stop it growing. We don't need to do everything. We don't need to do eradication. We need to do enough to stop it growing. And we need to do that in a very targeted way. So in a very roundabout way from your housing, it does come back to housing, it comes back to schools, it comes back to how we socialise. But they're very specific, and transport. They're very specific types of environment, and they're all solvable. Trying to be positive.
Orla, could you just repeat, you gave a shocking statistic there that 1/2 of the people who died in Ireland were in, I think you said...
They were infected in fewer than 400 buildings.
400 buildings, mostly nursing homes, I think.
They were the nursing homes. And in fact, in County Kildare, which has a lot of nursing homes, 90% of the deaths were in just 25% of the homes. So it's very, very environmentally specific and preventable. I suppose that's the key message. It's a preventable disease, and I'm really shocked this week that we're talking about acceptable deaths and the next pandemic. And we shouldn't be having these conversations. We don't have acceptable deaths from flu or from fire in buildings or from food safety. We have a strategic approach to have fire safety authorities and food safety and road safety, and we take an evidenced approach to prevention.
Orla, thank you so much for that. I'm going to ask James to come in here because I think your point about COVID being as much an environmental crisis as a medical one is a hugely important one for us as legislators, those in the political and policy-making sphere. That's an important message for us to hear, because certainly as we were grappling with it, as we were going through it, it was much more medicalised. And I suppose the expertise that was most, and I think all of you are agreeing, that the expertise that was most closely followed and closely watched and that had most impact on us in the policy making side, that expertise was medical expertise. And of course we didn't know. I mean, we're all sanitising hands frantically still, but actually the evidence is becoming much clearer that this is airborne and that therefore it's about buildings and environment and so on. So I think we're beginning to learn the more multidisciplinary approach that's necessary. So James, I suppose coming to you then, and again, you're very welcome, and it's great to have your expertise and experience within the National Health Service in Britain. You know, in terms of how you've come through COVID and the lessons that are learned there, you know, I don't know if you want to comment first on that concept of it as an environmental crisis as much as a medical one, or to say what lessons you think there are in Britain for the building of better health among communities, better public health, and what can you say about that? We'd love to hear from you.
Thank you very much. I mean, it's a delight to join you all this afternoon. Hello to everybody in Dublin and those online. And so I think in answer to your question, we've got this, I think, a paradigm shift to make in how we really understand what makes us well and how we use medicine and other potential interventions if we're truly going to meet some of the global challenges that we have for health and well-being. So, you know, modern medicine is fantastic. It's probably one of humanity's greatest achievements. And if you think about, you know, what we've achieved over just 100 years, you know, penicillin wasn't even discovered 100 years ago. And technology like MRI scanners, the ability to transplant hearts and lungs in human beings, the things that we survive now that we weren't surviving even a few years ago. And obviously, biomedicine has a massive role to play, and we're seeing the impact of biomedical advancements with things like the COVID-19 vaccination. But as we've been discussing, actually, you know, we know that there are limitations of biomedicine. We know that there are risks with an over-reliance on medicine. We're prescribing too many drugs. We have people addicted to opiates, many of which have a very low evidence base in terms of their effectiveness. And we have issues with antimicrobial resistance as well. We also see that at least 1 in 5 appointments with GPs, and this is true in Ireland as it is in England, are people seeing their GP because of a non-medical need. It may be loneliness or social isolation or debt or housing or relationships. And that creates a pressure on health systems where actually the danger is that we over-medicalise the solution. And a recent report by the University of Sheffield, actually, a couple of days ago, said that was 3.7 million people in Great Britain that are now lonely, and people are much more likely to visit their GP if they're living with loneliness. So the approach that we've got over here in England has been to adopt social prescribing at scale, and we're in the process of putting 4,500 people into primary care who can work as link workers or community connectors or social prescribers, who are working with people to find out what matters to them, to understand the barriers, maybe the societal barriers, the health barriers that they've got, the inequalities that they're perhaps facing in their lives that are preventing them from achieving their health outcomes, and enable them to be connected to activities in their community, to things that are going to help work through their issues. Now, whether or not that's activities, social activities in the arts or culture, whether it's sport and exercise to get people more active, whether it's the natural environment, because we know the power of nature. And all of this is about connecting people with ways to live their lives that are going to be better for them in the long run to achieve their outcomes. And the National Academy for Social Prescribing was set up to create this impetus of a challenge for the way in which we've been providing medicine over the past few years. Now, this isn't about acting as an alternative. This is about alongside biomedicine, but embracing the fact that we need to do something else. And in back to your question, your central question of whether or not the pandemic's been a social issue as well as a medical issue. Of course it has. We've seen, those communities that are facing the biggest challenges, those communities where unfortunately people are likely to die 10 to 15 years earlier in the most deprived communities versus those in the most affluent communities. We've seen more significant challenges for them, and actually, embracing a holistic approach, starting with what matters to people, creating the opportunities for people to connect to their communities has got to be key to an advancement in global health and well-being.
James, thank you so much. And you've explained the work of the National Academy for Social Prescribing, which is what I was going to ask you as a mere layperson. What did that mean? So I suppose, just to be clear, if somebody comes to a social prescriber, they're as likely to be advised to attend a meeting, a community meeting, or to go for what's called often a forest bath, to experience nature. Is that it, alongside perhaps any medical prescription, that's the ethos and ideology, or the philosophy behind the Academy?
Yeah, the philosophy is, so a GP will offer the individual the opportunity to connect with a link worker, connect with that social prescriber, and that they'll be able to give them some advice and guidance, work out a personal plan. And what's really important here is that it's based on what matters to that individual. It's the important thing is that this isn't imposed on them. It's not about finding something that works for one person and scaling it across the whole population. It's got to be something that's right. And then, a myriad of activities in the community. Forest bathing is fantastic. Getting people engaged in walking football or hiking, walking groups, singing for the brain groups for people with dementia. A huge range of activities that have got a growing evidence base in their impact on health and wellbeing outcomes.
Well, thank you. That's really good to hear, and an example of multidisciplinarity in practice. Clean, I want to just go to you to ask, is there any sign of that happening here? And I suppose we've discussed health in an Irish context. It must be a record for 20 minutes without anyone mentioning the S word, sláinte care. And of course, that is, for those who don't know, that is the blueprint for our reform of our healthcare system that will move us eventually towards a universal public access healthcare model like that upon which the NHS was, of course, based. And for those of us who are politicians from the left, like myself, from a social democratic or socialist tradition, for us, the NHS model of free access is the one. It's the one that will bring, that really is the big, if you like, the silver key to enabling us to have a more equal health service and to ensure that we don't have that inequality of outcomes that Orla's described from different nursing home residents and that we saw among marginalised communities. So, Cliona, what do you think? Would sláinte care make a difference, and could we bring in social prescribing under it?
Do I think sláinte care will make a difference? Absolutely. And I think I find it really encouraging that the majority of hospital consultants of my age are very, very strongly in favour of a universal health system. And yeah, the sooner the better from my point of view. I think I was delighted that I felt that sláinte care really recognises the increased need in certain pockets of society. There's this thing called the law of inverse care provision, which we've kind of touched on, which is usually the more you need something, the less you have access to it. So where there are the fewest GPs in the poorest communities with the highest levels of ill health, where is the funding lowest in hospitals like James is based in deprived areas that have much higher rates of illness and morbidity. So brilliant, strongly in favour of sláinte care. Social prescribing is great. I'm going to be a little bit controversial now and say that I think social prescribing is most important in that it gets the people working in the health system to think a little bit about the social context that their patients live in. And I would have the caveat that social prescribing is very much about the individual. And I think we really, really need to focus. I think the most important people for health that are here out of the four of us are yourself, Ivana, as a politician and policymaker. Seriously, like your decisions are going to impact way more people, way more profoundly than anything I do in my clinic. And Orla, who is able to inform that. And I think that we need to be very conscious of the fact that, political decisions around rising levels of inequality, for example, as we've seen in the UK, have effects on health which vastly outweigh any efforts to bring in more social prescribing. So that's my left-wing manifesto. I didn't hide my political position very well.
Okay, moving to the other side of the panel. I know both Orla and Gareth want to come in. Orla, I might go to you first. Just your observation on social prescribing, as a not like myself, a non-medic, and just more generally about Sláinte Care and what it could do in terms of equality of outcome, equality of access and equality of outcome, which is the design.
Well, what I know about Sláinte Care is probably no more than anybody you might stop in the street, so I won't go there. But what I would talk about, though, is if you think of the origins of a lot of the thoughts about public access or universal access to healthcare and universal access to housing, it comes from a position of betterment of the entire community. You know, we didn't have slum clearance in the past as a gesture to people who were living in poverty. We had it because they were engines of disease into the rest of the community. And when people were moved out of poor quality housing into better housing, the entire community did better and people had more access to employment and education. So housing is absolutely fundamental to this, and how communities are made, which I think ties into this. You know, we saw during the pandemic the communities where people had put down roots and had been there for a long time. I think of the community in Ringsend who were running bingo and dancing in the courtyard and things. The communities that are here a long time and have put down roots have a lot of soft support that do a lot of this work. But as we're making newer communities that are fracturing people into little atoms of housing and making it quite transient and making it very difficult for people to put down roots in terms of having security of tenure and having decent housing that's big enough for children and all those things, we are taking away all that soft support of community and making people much more dependent on state services and, as you say, going to the GP because they're lonely. So housing is really fundamental to this, and I don't think we're getting housing right. You know, we're designing the cities for people who are short-term residents in small rooms, and we're pushing the real need, which is family housing, further and further into unsustainable locations. So I would strongly echo the idea of the social side, or in the broadest sense, social and community aspects to all our lives being so important to our health and well-being. In terms of the actual delivery of it, I would defer to the people who know, you know, the detail of that.
Before I go to Gareth, Orla, just a question arising from that about you know, the access to housing and to decent quality housing and so on. I don't know if you saw an interesting argument by Michael McDowell, my former Shannon colleague, where he suggested, and it's an argument I've heard before, that by moving to better conditions, to requiring, as legislators, better conditions for apartment rental, effectively we close down bedsits, thereby creating a housing crisis because the ending of the traditional bedsit, and of course those bedsits were in memory always very grotty and poor quality and so on, but that we didn't replace them with any good quality.
Well, I don't actually agree with his analysis. There's nothing.
I thought you wouldn't.
well, I suppose he's blaming a slight change in regulation to improve people's living conditions and the people who are probably at the margins and needed better conditions and private bathrooms and space to store their own food. That's human dignity. I don't think there's anything wrong with that. He's blaming an improvement on standards for people living in those conditions for increase in prices when that's entirely due to financialisation and other pressures. And in fact, that financialisation pressure has lobbied for bedsits by the back door in co-living, where we could have 40 people sharing a kitchen. So I don't think his argument really, I wouldn't agree with his analysis.
Well, thanks for that. And, I agree with you about certainly. And co-living, I think the jury has now decided co-living is really not an appropriate model. So Gareth, just to come back to that point of universal access to healthcare, and that as a way of ensuring better quality of outcomes and better health. Do you think that's a fair analysis, that Sláinte Care would give us a better outcomes and better, as well as better access?
Well, firstly, I mean, human rights, you know, health is now a human right, you know, so that's clear, it's in the UN Charter, but I think we need to look at things from a policy perspective, as, you know, Cleona's spoken about, and even from your perspective. Look, the evidence is really quite clear here. If we invest in preventative care, and what I mean is ensuring that our children understand what it means to have healthy nutrition and make decisions about whether they exercise, and as they grow up, we will deliver high quality life, shall we say, for each individual. We will look at the social determinants of health, the sense of purpose that we have in our life, which is what gives us meaning, which is so important to our health and well-being. But we also have to look at leadership here. Professor Nolan spoke about it earlier. We need to start standing up and saying, we know what this does, we have the knowledge, we have the wisdom, which is the most important thing. We need to spread that wisdom and that understanding of what makes us healthy, okay? Myself, my colleagues here have worked in public health and advised governments for years. I worked in the Irish Health Service and I work now in a global context. I look at how do we create value from a monetary perspective as well, and housing is a prime example. Our housing stock is not fit for purpose, okay? We have built an environment that is not good for our health and well-being, okay? We see it with air pollution. Millions of lives are lost every year, okay? That's an environmental issue. We're facing climate change, okay? What are we doing? We know this is coming, so we have to prepare. But that gives us the opportunity to look at how do we change our model of health and well-being to support the current model, which we know has its advantages, but we also are lacking in many areas which can give us an opportunity to create new and meaningful jobs. And the jobs that we can create are in preventative medicine. And what do I mean? In schools, for example, mental health and well-being. Why do we not employ people to look after our children's mental health and well-being? It's fundamentally, if you put the finance numbers behind financing that, I'll give you an example. In the UK, if someone commits suicide, it's about 1.5 million that's lost from the exchequer, okay, from tax, okay? If you put a mental health nurse in, it'll about 30,000 per year, that's the salary, and you probably save about 30 lives. You do the maths there, that's well over 30 million. That's just a value proposition. And what I'm saying is we need to share that knowledge, we need to expand our programs. As part of the work that I'm working with the foundation, the UNGSII Foundation, which has been given the role to accelerate the 17 SDGs in cities around the world. And what we're doing is we're bringing the knowledge and the know-how, but we also bring the financial support. So the investment behind the new homes. We want to develop social housing, affordable housing, that are built on environmental concerns. You know, water, clean water, you know, energy consumption. These are massive issues that all play an important role in our health and well-being. So that's what we need to look at from a future context perspective.
Not an easy task either. Now, I've been told I've only a few minutes left, so I'm going to ask each of you in turn. James, starting with you, if I may, just what's the single change that's the most, I think, that you think, I should say, would have the most impact in terms of promotion of health, you know, that sort of preventative approach that we've been talking about, that more social approach to medicine. What's the single biggest change that we can make in a public health system or in our healthcare system? Do you have any lesson for us? And if you want to respond also on social prescribing, by all means do. I'm conscious you didn't get a chance to come back on that.
No, it's absolutely fine. I think the big piece of technology for me that we underuse in healthcare settings is conversation. Is actually finding out what matters to people, what the issues are, what the barriers are to them achieving good health and well-being. You know, starting with the individual, and the point about, you know, individual versus community. I get that, but you know, I think we need to embrace this at a big scale, and delivering more personalised care, improving agency for individuals. You know, technological advances, biomedical advances, all fantastic, but actually, I think we've got to really get underneath the skin of what is creating barriers for people achieving good health and well-being, and finding that individual and community agency to improve health. So that would be my one thing.
I love it. I love the idea of conversation as such and I think you're absolutely right. We don't recognise that enough. Orla, I might ask you the same question.
I didn't have time to think of one, so I'll have three. I would say public housing. We have to sort out the housing problem, and we have to make it affordable. And the second one I would say very much is safe schools, and that's COVID now. We have to do it immediately. We have to act on that immediately. We're going to have a difficult winter. Children are not protected with vaccines. And the third one, I think, is we need to stop thinking of housing as property. We need to design communities, because if we can get the communities right, we are improving well-being, mental health, physical health, access to employment and education, and that's opportunity for people.
You're really linking housing or homes and health as a crucial thing, and not just homes but schools as well. I think that's a lesson we're learning, all right, as we're going through. Cleona, how about you?
So I think my thing would be to recognise that poverty, and particularly social exclusion, which is an extreme form of poverty experienced by travellers, people are homeless, people in prison, has horrendous effects on people's health, and that we need to address that in every facet of our policies and planning. And I think a lot of how that happens is through difficulty in childhood, coming back to what Gareth said, when children are growing up in families where there really aren't the resources, psychological, material resources to give them the safe environment that they need, and that has very profound effects on people's behaviour. And I think we need to think about, instead of spending money on prisons and end-of-life care, to really go in and support families with young children.
That's a great, may I say, I think that's a great answer. I suppose my background is criminal law, and I'm very conscious, Gareth, when you speak about the monetary values, that difference in cost to the state of keeping someone in prison for a year versus keeping someone in community service, and the potential for rehabilitation, of course, is so much greater from community service. And something we're working on now in the political sphere, a universal public childcare system, which would give every child an equal start. And I think that's crucial in terms of public health. So Gareth, we'll go to you last for the last word on, and I've given you more of a chance to think of an answer in terms of what's the single biggest change for good in a public healthcare system.
It's the mindset. It's really our mindset has to change. At the moment, we see everything as a cost. Why are we looking at things from a cost perspective? Why are we not saying this is value creation? If we look at what public health does in terms of environment, it's all about creating value for our society. If we invest in prevention, from an example, we have a model, a pound invested, 36 back. Okay. We also, in the health service, remember, we have intellectual capital. Okay. That's what Google and Facebook based our whole model on, is intellectual capital and knowledge. Okay. We don't use that as a value creator. We actually, it's drained from the health system and then it's commercialized. We need to change the way we actually fundamentally think. And also, one of the areas is investments. When I was in the public health service, when I worked with the HSE and the Irish Public Health Service, where was my pension fund going? Because I would have loved my pension fund to be invested in the social housing that you're talking about, because I work with really clever people, one of them sitting in the audience there, Roland Schatz. They can give us a return on our pension fund of 53%. So we can then invest in the social programs that we need to, while making a return for our pension funds. So we need to ask those hard questions, transparency, building trust with our politicians, with those who are developing these policies. Let's have an open conversation about how do we finance our public health services for universal care? How is it financed? Honestly, tell me how it works. And have that open debate so that the community decides, I want my money to go into this public service. I want it to deliver, childcare, which is free for my daughter. I want my family to have a nice environment. Because let's be under no illusion here, there's plenty of capital, okay? If Jeff Bezos and these Elon Musk can send people to space, where are they getting the money for that, okay? We need to support companies that have ethical values and platforms that have ethical values and have a sustainable mandate that are going to invest in our public health and well-being. So that's mindset. We need to change it. So that's my words.
That's great. Okay, well, thank you all so much. And that's been a really stimulating discussion. I think the big lesson I'm taking away is, the need, which is something I believe in fervently, is the need to see spending on public services, health, housing, education, childcare, to see that spending as an investment rather than a cost to the state. And I think that is the change of mindset that we need. It's also, I suppose, a lesson we learned from the NHS and the wonderful speeches at the foundation of the National Health Service service after World War II. Coming out of that time of crisis in Britain, we saw such vision for change there, and that's the sort of vision for change that many of us are pushing for now as we come through COVID here in Ireland. And it's about ensuring that health and housing and education are seen as the human rights that the UN SDGs recognise them to be. So I think those are really important messages. I'd like to thank all of you, James, Cleona, Gareth and Orla. Thank you so much for giving us your expertise for the last 45 minutes or so, and thanks to all who are joining us online and here in person, and I know we'll be back shortly with the next session. So Gura Maith Galer, thanks for joining us.